Hi, everyone. It's Rob Green here. I'm the co-chair for the Benefits Alliance Voice. And with me today are two special guests, Carolyne Eagan, our Benefits Alliance president, and Graham Young, our board chair and partner over at CapCorp in Ottawa. So thanks for being here. It's Wednesday, May 29th, and we're doing this special podcast to update all our listeners on something important that happened last Friday in Ottawa, the federal parliament hearings as part of the legislative process for the Standing Committee on Health Studies. So Graham, probably first off, why was it important we were there on Friday?
I think it's massively important that we were there to share our perspective and share our clients' perspective on what we think of this current healthcare Pharmacare legislation. We want to make sure that the voices of plan members that we hear from every day who are having challenges getting their drugs or navigating public, private, all of that, we want to make sure we were on record for what we can do to help.
And Carolyne, you were there also representing a larger organization that Benefits Alliance spearheaded, and that's the Smart Health Benefits. Maybe speak to the coalition that we've got working together.
One of the proudest things I would say for Benefits Alliance in our advocacy efforts, because we just started this journey 18 short months ago, is last fall we saw the attention being paid to Pharmacare and what's on the table. We also saw that we are a unique voice unto ourselves, representing advisors and plan sponsors, ultimately Canadians in the benefit space. And what we recognized is if we want to have an impact louder, faster, let's invite other organizations that would share this voice with us to the table. And we successfully, within 6 to 8 short weeks, had Gallagher, Group Health Benefit Solutions, Hub, Navicord, and People Corporation come and join forces. And we ultimately quickly formed the Smart Health Benefits Coalition. So together, we represent over 65,000 plan sponsors, 4,800 of which are union plans, and ultimately over 10 million Canadians. Now, I will add that in the last couple of months, we also added in CALU, the Conference for Advanced Life Underwriting. What this means is we have thousands of advisors across Canada in every province that see how Canadians interact with the public and employer-paid systems and what that experience looks like. So our voice is valuable at the table, and we have seen that. And this is ultimately what led to us getting a very special invitation to this committee.
So why should people care, Carolyne, that we were there on our clients' behalf on Friday?
Ultimately, we care about people's health. This is a big risk of what's at stake, of how people will navigate and access care. Now, number one, I want to be absolutely clear, like, what is this Pharmacare bill? Let's talk about that. Number one, what's on the table is to ultimately bring free access to Canadians for 2 specific conditions. And number one being diabetes, and number 2 for looking after your own sexual health with contraceptives. So there are a number of Canadians out there that have no coverage, no insurance, whether it's public or private. So we agree it is very important. Yes, let's get help, but ultimately that's about 3% of the population that have no coverage. However, we would say there are studies out there or reports that we've heard in the news, in the politics that say, we've heard Jagmeet Singh as an example, 22% of people report having difficulty pay for those medications. So number one, I'll just state pure and simple, we agree, let's get help to those Canadians.
Absolutely. Absolutely. Mm-hmm. Graham, what was your perspective of Friday's hearing?
It was interesting seeing the different perspectives because there were other organizations that were there representing their perspective as well. And to be honest with you, it was my first time seeing that level of parliamentary process, which was interesting in itself too, because there's a lot of rules, there's a lot of protocol and timing and questions that get asked as follow-up. And it is an interesting process. This was a very quick one because they did actually limit the amount of time that they have for this exercise. Normally there's a little longer period, and they seem to be eager to get the legislation through. Definitely a learning experience, but definitely happy to be there and be a part of it. I don't like being a passenger and watching things go. I want to be in there to help.
That's right. That's why we're here. That's why we do what we do. Carolyne, do you feel like we were heard?
I do. I feel like we have been heard in the past few months, and that's what ultimately got us the invitation. I think we do have a unique perspective and understanding. So What was most interesting to me, Rob, though, is the meetings leading up to that day and even during, there were multiple stakeholders, multiple witnesses at committee that kept bringing up the same concern. And that would be that there's a part of the bill that specifically states that the way people would get this coverage is universal single payer first dollar coverage. And it's important that people understand what that means. And what it means is, as per the Canada Health Act, only the public system can pay for that. So employer paid systems, insurance companies would no longer be permitted. Now, having said that, a lot of people expressed, worry and concern. Our position would be, why spend $4 billion of valuable resources and money on something that is already helping people achieve their health, 4 to 5 Canadians that have that employer paid coverage without issue? Why not take that money and either expand the list of medications that are covered under those health conditions, or actually repurpose that in some of the other pain points in our industry? So I'll bring it back to say it was very interesting to me that multiple people expressed concern over that wording. And what was most, I'd say, encouraging was that the health minister himself, Mr. Holland, is saying that people would have choice. They could choose to use the public or the employer paid system. So obviously that's opposite of what is written in the bill based on our understanding. So we're encouraged that if the intention truly is to have that multi-payer system, which is well needed to afford what we're going to do and be able to help Canadians, but there still remains that question mark of how the bill is written, and we feel very strongly that that should be paid attention to and be written in the way that does not have unintended consequences.
I'll add to this because the immediate thought of an employer is like, hey, if somebody's going to pay for some of the drugs that are going through my plan, this is great. And I think on the surface, we wouldn't disagree with that. The issue is the plan member experience and the Canadian experience, right? We're already struggling where people are getting bounced around from whether it's their private plan or accessing a government plan or accessing support from a manufacturer, from a drug company. What we're really worried about is how that experience is going to get worse. What's the delivery system and how do you get on it, and will it really be? Could it be coordinated with an employer plan or not? So that's our biggest fear, is just the best asset of a benefit program is getting somebody what they need so that they can get back to work, right?
Absolutely.
Yeah.
And I'll add to that too, the confusion around, who understands, what's on a public list of drugs versus an employer paid list of drugs. And I think there's two important things to note here. Number one, an employer list of drugs, depending on the province you're in, is going to have coverage that has 40 to 50% more drugs on the list of conditions. So let's take diabetes, for example. There's going to be a list under the public system that is going to cover some basic, metformin, those types of drugs. However, maybe some of those higher cost, more impactful drugs that are working for people's health that are newer, they're not going to be on the list, but they are on the employer list. So
Ozempic would be coming
yeah,
to
exactly,
right?
exactly.
And even some kinds of insulin. So
Correct.
A lot of the formulary that they're talking about is very specific, lower cost generic options, which that's a great start, but we know that employer plans cover a lot more.
Yeah. So
and it's one thing to have it to say like, yeah, we're going to cover it, but then have a big asterisk in font 4.
Yeah.
It's like, oh, but here's all the restrictions. And you're right, the lack of clarity, that all the questions I think that our firms get, Graham, when it comes to what's been covered, or why wasn't this covered, that we're doing it.
Yeah.
Now times that by 30 million people.
And
right?
and unfortunately, it's the talking point of politics, right? We live in a world where it's all about headlines and talking points. And we have folks who are going around saying it's going to be free drugs. And that asterisk is going to be the real hard part to get around. Like, what's the real coverage that we're talking about?
Yeah, and so our position, making smart solutions with the Smart Health Benefits Coalition, that's why we're called that. We have great insights, we have great solutions. Let's not be quick to spend dollars where you don't need to spend them. So in this specific example, why not repurpose the dollars, that $4 billion that I referenced, to actually make that list of drugs longer? Or in fact, why not create a system where you can actually have free drugs for those that don't have any coverage for other health conditions. There's great needs out there beyond these. So we're a fill the gaps approach. Let's cover people who have no coverage or can't afford even their copay. Because let's face it, maybe even a $20 copay that someone has they may struggle with that. Let's help them. So that's one aspect. The second aspect that people may not realize is under employer paid plans is that people have access to those newer drugs faster. In fact, 500 days faster on average than a public plan. There's just different systems that things go through. So I think the value that employers and employees need to understand is that the employer paid plan today, your benefits package has more drugs covered, again, 40 to 50% more drugs covered, and you have access to those newer therapies faster than otherwise. So those are key points. So number one, let's make sure that wording is the intention. If we want to, we're encouraged again that the minister is saying people would have choice. Let's make sure that that's how the bill is written. Graham, what else did you observe that day?
Well, I observed that a lot of folks around the table who were witnesses were all agreeing that this was a very important conversation we need to have, but it's happening too fast.
So, yeah, and I think it sounds like it went through the House, did it not?
So it's just going through. They put through a few amendments. So maybe that's just good to level set on the process.
Yeah,
I had to go back to my high school learning to figure this out again. So when a bill gets put on the floor of Parliament, it goes through first reading, and first reading is just here's the bill, no real talk about it. Then it goes to second reading, and that's when there's a little bit more debate about it. And in second reading, they have this committee process that we just had. And then coming out of the committee, it goes into a final second reading, and then a third reading is what pushes it to the Senate. So when it gets to the Senate, it basically goes through the exact same thing over again. So first reading, second reading, committee. Traditionally, the Senate is supposed to be that sober second thought to see if things are being put through with the right intent. So we're hoping to be at that committee again and try to talk to them about some of the challenges we see in it. There was only a few amendments put through. We are pleased that one of the ones that we were recommending was put in there, and it was that there needs to be some public accounting on whatever this looks like, some public reporting on it before any further decisions are made. So let's assess this if this goes through and it gets implemented. Let's not go any further until we really take a look at what this costs.
So where are we at now with the bill?
So it's just about to go through this final reading on the second reading. So we think that really they only have the next few weeks to get it through a third reading and then push it to the Senate, because then obviously our members of Parliament take a little bit of a break and get back in their ridings in the summer. So at best case scenario, it could become law sometime in the fall. That's assuming the Senate doesn't change anything, right? So the moment the Senate changes anything in it, it goes right back to the House and we start all over again. So that's where we're at today.
So what's our position going forward then?
Our position is to really just get back to the table at the Senate and keep talking about, we've suggested two other changes. The big talk is cost of drugs, right? So we have this world where the public plans sort of pool things together and buy drugs together, and then the private plans go on their own. We think if we're talking about the cost of drugs, we realistically have to talk about all of drugs in Canada. The private world and the public world spend about the same amount on drugs, so why don't we pool that together? So we've suggested they do that through what's called the PCPA, which is a mechanism to buy drugs in bulk.
One of the principles and with this bill is that all Canadians would have access to free medication. Now, this is a provincial negotiating tool, actually. So the health minister would go to each province. And so we've proposed as an amendment to the bill that should a province, should discussions break down and they say no to this proposal, what would that mean to a Canadian? Ultimately, it would mean in that province, they would not have access to the free contraceptives and diabetes medications on the list, which, because it's a single payer first dollar public model, we don't want anyone to be left behind, right? If the purpose is to provide this to all Canadians, someone in that province would be left behind. So our proposal for an amendment would be, should that negotiation break down, that the province be allowed to have a secondary negotiation and enter in an agreement that allows for a multi-payer system, meaning both public and employer systems could pay, and then you could proceed to wrap around and decide your program, because it is a provincial decision.
I think that's important for
know.
people to understand. It's the federal government can't just say we're going to do this unilaterally. It's healthcare is run by the province. Great point.
Yeah.
What from this do you want advisors to understand, Graham? One, and maybe Caroline's second question would be, if you're running a business or a company, like, or an organization, nonprofit, what should they understand? So maybe Graham first, from, if you're a benefit advisor listening today.
This is a really important conversation, and please talk to everybody about this, because this is so critical to our healthcare conversation. But I think that the first point is, obviously it's not law yet. And then it's just that we have to figure out what happens in each province. And this is the challenge for advisors, especially advisors like our shop who deal with people in different provinces. You've got to navigate it as it comes. So we're going to be following that pretty closely, and we'll obviously update people as we hear.
Okay, great. Caroline?
Yeah, I think from an employer perspective, I mean, I'll just say this. We see it through the dental program. We see it now through this Pharmacare program. Any changes that impact, never assume you think, there's an approach, a next step to modify your plan. Talk to the advisor, talk to your benefits advisor to really understand that impact. Because again, as Graham said, people may perceive, okay, great, they're going to pay, I'm going to save money. You don't know that list is shorter and that the wait time for new medications is longer. So let's take that step. But I think it's important too for employers who may be feeling, we would say there's other pain points that are experienced. And I think everyone can relate to high cost drugs. Everyone today is seeing a plan member who is on a drug that is over $10,000. Some are 50, some are 100. And I will invite, because Graham's got a few examples here. At the moment, this is where we would say the dollars need to go where the pain is. And so the pain points are people that can't afford basic medications. Let's get them help, but let's also repurpose dollars towards figuring out a national strategy for high cost and rare disease. The money that is currently allocated is $1.5 billion over 3 years. It's truly not enough to make a meaningful strategy. So some of these $4 billion that I'm talking about could be reallocated there and figure out how to get more people access to high cost drugs, even for that 20% out of pocket that really could be unto itself $10,000. So that's our position, is help both ends of the spectrum. But I really do think I want to invite Graham to share a few examples that people can relate to.
And that's really why we got into this conversation, because we see the impact of an employee or a Canadian trying to figure out what happens when they have a serious illness, right? And so we had one recently in our office that the employee was diagnosed with cancer. The oncologist in the hospital wrote them a prescription and said, you need to go fill this, but I'd like you to come back and we're going to supervise you taking this. And so when that happens, because of the way the Health Act is written, it's very much, according to the insurance companies, it's very much illegal for them to pay for that drug because it's being administered in a hospital. And so you've now got this employee who's, faced with this awful diagnosis that they're trying to get, start their treatment. It's massive, life-changing, impacting. All they should be worried about is getting better. Yet they're now sitting there going, well, the insurance company's not paying for it. The hospital's not paying for it. And oh my goodness, this drug is $10,000 a pop. So that is the real problem in Canada that we need to deal with. We all typically believe that if we get cancer, we will be taken care of in the hospital. That's what everybody believes about Canada. And the reality is it's not the case, especially with the number of cancer drugs that are coming out that are a pill and not the traditional chemotherapy in the hospital.
Absolutely right. And, it's my biggest fear is that we're starting to shift down that American road where people are making decisions. Well, maybe I can't take that expensive drug, right? Because I can't afford it, or I have a copay on it. And you're absolutely right. We've talked about this. Think of what companies could do with benefit plans, the more the options they can provide and strategies they can provide, if these high cost drugs were where they should be, is burden on a national level that the government could buy it for everyone, like for everybody across the board, coast to coast. You're absolutely right.
Yeah. I'm going to add one more example that maybe people can relate to as well is, a good friend of mine has two daughters with Crohn's disease, and they're both in university right now, and one of them is about to graduate. So I'll pick the eldest daughter. Her annual cost of her medication is $52,000. And thankfully, dad has a 100% plan. Now, imagine she's graduating, and when talk about the stress of like looking for a job, what will my new employer team look like? What will my job duties be? Will I have an environment that I like? What does that look like? But what's her number one question is, will they have 100% coverage, or will it be an 80% plan where I have to come up with $10,000 a year? Not only that, but do I need to live at home or live away from home? Because if I live away from home, then I have a greater chance of maybe accessing public dollars. So we've talked a bit about this with Gary Walters on the Drug for Rare Disease. He's a member of our Smart Health Benefits Coalition. And, these are some of the solutions that we want innovation to continue to come to Canada because it changes lives. People remain active and healthy at work. And so to pay for that innovation, we need to figure out that question. Do we have all the answers? No, but I think having a number of people around the table, you need government, you need pharma, you need insurance, you need advisors, you need everybody. This is not easy to figure out, but we've got lots of provincial and world examples that we can learn from.
Well, where most of our provincial tax dollars go as a percentage of what we pay in taxes towards healthcare, we should want to have access to the best of the best and to the smartest minds. And we want to ensure these medications keep coming to Canada. Yeah. Like there's life-changing medications out there, but unfortunately there's some that never make it here, or they make it here years after they've been deployed in other countries. So
I'm sure I'm going to get the stat wrong, but I think it's like half the drugs that are created don't come to Canada.
I think you're right on that, Graham. It's real close to that. We'll put an asterisk in the notes, but that you're absolutely right. And I think just more so that we're not saying no, we're just saying that we think there could be a better potential way of doing it. So so Graham, Carolyne, thank you for being there on your behalf. You did that in your own time. And I don't know, any closing thoughts from either side about next steps? And
yeah, I think I would just comment that, Benefits Alliance in conjunction with the formation of Smart Health Benefits Coalition, I think that as an industry, we've recognized coming together as this voice is valuable. And, today our topic is Pharmacare, and we would want to be continuing in having these insights shared. So please, any of the listeners today, stay educated, stay informed, follow us on our website, for Smart Health Benefits Coalition. You'll see where this goes and where other topics go as well.
Yeah, and the websites we posted in the show notes, and that'll be great. We want people there. Yeah. Great. Thanks for your time.
Awesome. Thanks, Rob.